Hi, and welcome to the show where we share the stories of the many who intersect with our healthcare system but are rarely heard from. My name is Kevin Pho, founder and editor of KevinMD. Today on the show, we have Adeel Khan. He is a hematology-oncology fellow, and he wrote the KevinMD article, Ruth Bader Ginsburg and Chadwick Boseman, A Tale of Two Cancers in America. Adeel, welcome to the show.
Thank you for having me. Pleasure to be here.
We'll get into your article in a little bit, but first off, can you share your story and your journey to where you are today?
Yeah, absolutely. So I'm a second-year fellow of hematology-oncology at Beth Israel Deaconess Medical Center in Harvard Med School. I did my medical school training at the University of Michigan, did my internal medicine residency at the Cleveland Clinic, and along the way, I did 2 public health degrees at Harvard and Columbia. And so I've been very interested in the intersection of medicine and public health, the way that medicine looks at patients as a granular entity and the way that public health looks at patients as a population and a large entity.
All right, and we're speaking on the last week of January. Now, what are you seeing from a pandemic standpoint through your lens as a hematology-oncology fellow?
Yeah, I think, one of the interesting things that's been a feature of COVID-19 is the blood clots and coagulopathies that we've seen. It's a viral illness, it's a respiratory illness fundamentally, but it really causes an interesting cascade of issues. And one thing that we've seen really from the heme side is that these patients develop unusual blood clots, and it's been called COVID toes when we see it in the toes. We've seen patients with pulmonary emboli, clots in the lungs. And I don't think this was anything that anyone had expected prior to it being characterized over the course of the illness. Fundamentally, it was seen to be a type of pneumonia. So this, I think, is a surprise to many people, and yet now it's very well established.
Now, I see patients with mild cases of COVID from my practice as an internal medicine primary care physician. As far as you know, is there any data supporting any treatments that we can stop this coagulopathy for people with asymptomatic or even mild cases of COVID in the outpatient setting?
It's a great question. On the inpatient side, for people once they're in the hospital, and particularly once they're in the ICU, we tend to anticoagulate them with heparin or another anticoagulant kind of automatically. That's been a controversial issue. People have said different things. We've seen some higher rates of heparin-induced thrombocytopenia as a result. We've certainly seen bleeds also as a result. So the overall answer is, I don't know that there is a right answer, and I don't think anyone knows. And so being a gray area, it's hard to say.
And as far as you know, is there any evidence supporting something like a baby aspirin?
Not as far as I know. I mean, it's more an issue, it's a less an issue of a platelet effect, more of the coagulation factors. And hence, if we really want to treat it, we need an anticoagulant, but then that enters into the bleed risk and everything that goes with it.
Sure. All right, so let's transition now into your KevinMD article, Ruth Bader Ginsburg and Chadwick Boseman, A Tale of Two Cancers in America. Now, for those who didn't read that article, can you just walk my audience through it and share the story of why you decided to write it?
Yeah, absolutely. So, 2020 was a tragedy in so many ways, made up of many small tragedies. And amongst them was the loss of Ruth Bader Ginsburg, a champion of gender equality, and Chadwick Boseman, who was such a celebrated actor. It was interesting to me as an oncology fellow that their deaths was spaced by less than a month apart, both of a GI cancer, and yet their circumstances really could not be any more different. Ruth Bader Ginsburg was 87 years old. Chadwick Boseman was 43. He was diagnosed at a rather late stage of colon cancer back when he was 39 years old. And Ruth Bader Ginsburg this was her third malignancy she had dealt with. She originally actually had colon cancer at the age of 66. She later had lung cancer that was resected. And then what she ultimately passed of was pancreatic cancer, which had metastasized to her liver. And the attention brought to both cases and to celebrate the lives of each was appropriate. But when I looked at the lens of what just happened in this past month, it was interesting that the racial disparity in these outcomes of these two people was really striking to me.
Can you tell us a story of how racial disparities in cancer treatment and prevention plays out in some of the patients that you've seen in the past?
Yeah, it's such a heavy question, and so many individuals have looked at this. There's an entire segment of the NCI that's dedicated to cancer disparities. There's an entire journal simply called Cancer Health Disparities. And what we've seen over years and years of research is that it really goes from womb to tomb, is sort of the phrase, that there are prenatal risk factors and genetic and epigenetic changes that can occur. And then later in life, there's many system issues which have brought up quite a bit of attention, from lack of trust in the system on the part of certain minority populations, to lack of access to appropriate clinical trials, to fundamentally the fact that the healthcare system is uneven in the way that it treats patients. And we see that then ultimately in patients' cancer incidence rates and their subsequent mortality.
So tell us, in a specific case of colon cancer, for instance, like Mr. Boseman, how does these racial disparities kind of stack the deck against him?
What was unfortunate about Chadwick Boseman was that he was diagnosed at the age of 39. This is well before the age of screening in anyone. Standardly in the United States, you get your screening colonoscopy at the age of 50. There's some guidelines now that say 45. He was younger than both of those ages. And we've actually seen a trend in the US, and it's been published before, that the age of colon cancer has gone down and down and down. And it's been postulated that might be obesity, a lot of lifestyle risk factors. But that decline in age is actually unequal. We see that for whatever reason, African-American Blacks tend to have more of this shared burden than do whites. And again, it's not clear why that is. The lifestyle hypothesis has been a big one, but I don't know that that's the only story. The other piece is that we know that a screening colonoscopy is associated with like a 50 to 60% increase in the incidence of colon cancer, meaning that if you screen someone at the age of 50, you find something that was there when they were 49. So it has nothing to do with the age per se, but that the precursor lesions you only find when you screen for them. And if you don't screen these people, you don't find them. And so they would present later, and as is actually what happened with Chadwick Boseman. So he was 39, diagnosed with stage 3 colon cancer. Now on the flip side, Ruth Bader Ginsburg was 66. She was well beyond the age of screening. She had great health care. She was a fortunate segment of the population. And so between the age of 39 and to the age of 66, where you see an advanced colon cancer case versus one that was ultimately essentially in remission and cured, Ruth Bader Ginsburg died of pancreatic cancer, that's a wide chasm.
So what are some solutions here, and both from a policy global standpoint, and what are some of the things that I can do as an individual primary care physician in the exam room?
Yeah, it's a great question. So for one, I would say, we as physicians, we tend to look at the patient once they're in the exam room. And I don't know that we always give enough thought into how the patient got to the exam room. What are all the forces that got that person sick? Anthony Eaton, who's he's a California-based physician who was originally from Montreal, Canada, and he talks about how they had such an excellent health system there. The racial disparity in health is not seen in the same way that it is in the U.S. And it's something he only noted when he came to medical school at Johns Hopkins and he saw the situation in Baltimore. He has a great quote that the key to your health lies more in perhaps your zip code rather than your genetic code. And I'm paraphrasing that. I'm sure butchering that in one way or the other. And it just highlights the importance of the socioeconomic aspect of someone's health. And so the big answer to the question is we really need a better system. There's only so much that we can do as physicians, and one is being aware and trying to be mindful of these issues and disparity, trying to appropriate more focus to one patient versus another. But we need to change the colossus that is our healthcare system to try to address these things.
So what kind of changes specifically would be needed? And do you think the Biden administration's plan is doing enough to make those changes?
So one thing that's been a big issue with cancer health disparities in particular has been an issue of clinical trials and clinical trial access. So for instance, African-American men have the highest burden of colon cancer, as we've been talking about a bit. And yet they're not at all the best study group. It continues to be white males. And yet again, they're not sharing the same burden per capita. And part of that is a feature of just the fact that it's harder to study certain minority populations, which may be an aspect of trust in the system, but also just simply access. They may not live in areas where there's a tertiary care hospital, where there's a research institution. And so one step is that we need to get data on these people. We need to involve them in clinical trials, because that would also help highlight some of the differences in what they are facing versus a white individual or an Asian individual. In terms of what the White House can and I hope will do is, one, I'm very optimistic that we'll see some positive changes, because 2020, one thing that we've seen and discussed over and over again is that COVID-19, it's not an across the board illness. It tends to affect more populations than others, including minorities. And that, again, is probably a systems issue. There are probably a lot of forces at play. But regardless of the reasons, people are aware of it, and there are attempts to try to address it. And I think as an extension of that, we'll see that extending to the chronic diseases like heart disease and cancer.
We're talking to Adeel Khan. He is a hematology-oncology fellow, and he wrote the KevinMD article, Ruth Bader Ginsburg and Chadwick Boseman, A Tale of Two Cancers in America. Adeel, through your lens as a hematology-oncology physician and a public health expert, now what are some tips that you could share with your primary care colleagues into how to address some of these racial disparities in cancer treatment that you've been talking about?
One thing I would say is look beyond simply the exam room. Think of why the patient got sick and recognize that the patient comes from a source population. They may also have family members who are at risk for the same reasons, whether it's a lifestyle issue or an exposure issue. And so being mindful of that and sharing that information with the patient is, I think, essential. The other thing is knowing that some people may take more effort on the part of you as a physician to get that screening colonoscopy, to get that PSA checked, to get them in the clinic, to get the appropriate care. And putting in that effort is more than worthwhile. And then fundamentally realizing that we need systems changes. And so what we can do by putting pen to paper, speaking to our representatives, trying to address the healthcare system as a colossus, go leaps and bounds.
And my final question, what is your take-home message you want to leave with the KevinMD audience?
Racial disparities exist in America, but they don't have to, especially in the form that they do now. We can and should have a more equitable system.
Adeel, thank you so much for sharing your time and insight, and thanks again for being on the show.
Thank you for having me. Appreciate it.